Good morning, good afternoon, good evening, friends, colleagues, students, mentees, and lupus enthusiasts. It is my distinct privilege to welcome you all to the Lupus Academy Roadshow this morning. This activity is supported and initiated by University of Santo Tomas, Department of Internal Medicine, Section of Rheumatology, in partnership with the Lupus Academy and the Philippine Rheumatology Association. It's been more than a year where our lives have been affected in so many ways by the first bug, COVID-19. It has disrupted our daily norms, isolated most of us from our families, friends, and patients. Despite the numerous scientific publications on COVID-19, we still have a lot more to learn about this virus and its effect on patients with autoimmune diseases. Hence, we thought of organizing this webinar to shed some more light, learn, and challenge ourselves to think of ways on how to protect ourselves and patients from this invisible enemy. I'm Dr. Julie Liu from the University of Santo Tomas Faculty of Medicine and Surgery. I'll be one of your co-hosts this morning and your moderator. With me is none other than my professor, our mentor, Professor Sandra Navarra from UST Faculty of Medicine and Surgery. She heads the Education Committee and the Lupus Special Interest Group of the Asia-Pacific League of Associations for Rheumatology. She's the prime mover of the lupus-inspired advocacy and the people empowerment for arthritis and lupus movement. She's the founding and executive committee member of Lupus Academy, the Asia-Pacific Lupus Collaboration, and Asian Lupus Nephritis Network. She's our go-to colleague when we encounter difficult lupus, and her passion and dedication is insurmountable when it comes to lupus. And allow me as well to introduce our three esteemed speakers for this morning. Our first speaker is Professor Eloisa Bonfa. She's a physician-in-chief of the Rheumatology Division of Hospital das Clínicas da Universidade de São Paulo in Brazil. This is the largest tertiary referral center for autoimmune rheumatic disorders in Latin America. Her main clinical and research interest is systemic lupus erythematosus and autoimmunity. She has published several papers on vaccine immunogenicity and safety in autoimmune disorders. More recently, she has been dedicated to monitoring hydroxychloroquine blood levels in lupus patients. She's a member of the Lupus Academy Steering Committee and has been involved in planning several activities of the Lupus Academy. Our next speaker is Professor Ricard Cervera, a co-founder and head of the Department of Autoimmune Diseases at Hospital Clinic in Barcelona. He leads the research team on systemic autoimmune diseases at the Institut de Investigaciones Biomèdiques Auguste Pierre Sunyer and professor at the University of Barcelona, where he coordinates the master's course on autoimmune diseases and serves as the Vice Dean of Academic Affairs and International Relations at its Faculty of Medicine and Health Sciences. He's an associate editor of the journal Lupus Science and Medicine and is on the editorial boards of 20 medical journals. His main research interests include clinical and epidemiological aspects of systemic autoimmune diseases, particularly lupus and antiphospholipid syndrome. He is also a member of the Lupus Academy Steering Committee. And last but not the least is our very own Dr. Ivan Glenn Visa. He's an associate professor of the Department of Medicine, St. Luke's College of Medicine, member of the Fellowship Training Committee and hospital staff at UST Hospital. He's an associate research scientist at Oklahoma Medical Research Foundation, Department of Arthritis and Clinical Immunology. He serves as the National Medical Youth Advisor of Psoriasis Philippines and a Board of Trustee of the Philippine Rheumatology Association. So friends, colleagues, lupus enthusiasts, let us all sit back, relax, and learn from the experts. Thank you for listening.
Good morning, dear colleagues and friends. I am thankful to the Lupus Academy for this initiative. I am tasked to present Lupus and COVID-19 Convergent Pathways. I have no industry disclosure for this particular session. For my talk, I divided into three parts. First, I will briefly discuss cytokine storm syndrome. Then I'll present the intricate and overlapping relationship between severe COVID-19 infection and autoimmunity in systemic lupus erythematosus. And lastly, I'll briefly discuss treatment and prevention paradigm shifts for severe to critical COVID-19 pneumonia. At this point, during the pandemic, we have already elucidated the clinical course of COVID-19 infection. It's divided into three stages based on the elegant article of Siddiqui's group. The first stage is the early infection, wherein you have the viral response phase, wherein the virus replicates. It would be manifested with mild constitutional symptoms as expected, like any other upper respiratory tract infection, non-specific. You have dry cough, even diarrhea, and headache. When you look into their labs, the patients would have lymphopenia consistent with the viral infection. There will be increased D-dimer and LDH, but not markedly elevated. The second stage is the full pulmonary phase. It is further subdivided into two subgroups, the 2A and the 2B stages. The 2A will be presenting with continuous viral replication, and it will be encompassing a host inflammatory response phase. You will present with shortness of breath, there will be hypoxia, and on radiograph, there will be abnormal chest imaging findings. There will be low to normal procalcitonin, distinguishing bacterial infection. The 2B stage, you will have persistence of the host inflammatory response phase up to the point that it enters the hyperinflammation phase, the last stage, stage 3, wherein the viral replication is now predominated by a host inflammatory response phase. At this point, patients present with severe to critical COVID-19 pneumonia, manifesting as an acute respiratory distress. There will be patients who would have sears or shock, and even cardiac failure. They are prone or predisposed to develop a multi-organ dysfunction syndrome, and they will have markedly elevated inflammatory markers like your CRP, LDH, interleukin-6, D-dimer, and ferritin being markedly elevated. This host inflammatory response phase is the stage in the hyperinflammation phase that we consider the possibility or the potential for this patient to develop a complication, which is cytokine storm secondary to COVID-19. Now, who develops severe to critical COVID-19 pneumonia? Even during the early months of the pandemic, we have established that many of the patients, majority of them will recover. At least 14% will develop severe disease. And this patient will present with respiratory symptoms such as dyspnea, tachypnea, and a decreased O2 saturation as well as PF ratio, and the presence of lung infiltrates within 24 to 48 hours of infection. 6.1% will have critical disease, and we need to catch this because this patient with the potential to develop multiple organ dysfunction will be the one who could have the cytokine storm. How do we define CSS or cytokine storm syndrome? Simply put, it's a hyperinflammatory syndrome characterized by a fulminant and fatal hypercytokinin that has a sequela of multi-organ failure. There are other established hyperinflammatory syndromes, particularly in the field of rheumatology, and we are commonly know this condition as macrophage activation syndrome. You can also interchange this with reactive hemophagocytic syndrome, as well as the primary and secondary hemophagocytic lymphohistiocytosis. It has a significant mortality among several cohorts, and in a cohort of patients of adults onset Still's disease, 13 out of 16 patients died with a mortality of at least 80%. Who develops this CSS? As I've mentioned, in rheumatology, rheumatic disease patients could have what we term as macrophage activation syndrome. So we see them among many overlapping autoimmune diseases, including SLE, systemic JIA or juvenile idiopathic arthritis, those with adult onset Still's disease, certain malignancies, and drugs, particularly those who underwent chimeric antigen receptor therapy, a form of immune therapy for specific malignancies like lymphomas. The group of Crohn has postulated that around 15% of serious infections are prone or could have developed cytokine storm. Going back to the pandemic, there are historical perspectives that we can learn upon. It has been postulated to be the cause of death among young, healthy people during the last pandemic of the 20th century. It has been described as well in the previous epidemics of the coronavirus, the SARS epidemic in Hong Kong, as well as the Middle East coronavirus. In the last pandemic of the 21st century, a decade ago, the AH1N1, it has also been similarly described. And during the early months of pandemic, parallel clinical data have been described or reported among infected patients in Wuhan as well as in Italy, where the outbreak, before it became a whole pandemic, began. Broadly, we can divide the immune system with innate immunity and adaptive immunity. As we all know, a microbe like a virus will activate your innate immunity initially and acts within hours. Eventually, your adaptive immunity will be activated and it will encompass several days. And the primary cells that are composed of your adaptive immunity will be your lymphocytes, the T cells and the B cells. What happens with cytokine storm is that if you have an overactive immune system, you develop this. Now, looking into systemic lupus erythematosus, we know that the hallmark of the disease is autoantibody production. And just like the microbes, but you don't need a foreign antigen, you have autoantigens. This will activate simultaneously both your innate and adaptive immunity. What happens with your lupus is that there is an immune dysregulation, thereby provoking and promoting further autoantibody production. We proceed now to the relationship between lupus and COVID-19. What have we learned so far? We know that your lupus has complex genes. There is not a single gene that is responsible for the development of lupus. There are several susceptible genes that has been described, more than 40, and the concordance among monozygotic twins will be around 40%. What happens with lupus is there is decreased innate immunity and an aberrant adaptive immunity. But as I've mentioned, the hallmark of the disease are autoantibody production, both to nuclear and cytoplasmic antigens. Looking into the parallels in the current pandemic and the role of COVID-19 or SARS-CoV-2 infection to the development of cytokine storm, I look back to several seminal studies for lupus, particularly with my previous stint at the Department of Arthritis and Clinical Immunology in OMR under the University of Oklahoma Health Science Center system. The aim of the department is to understand the etiology and pathogenesis of systemic autoimmune disease, particularly the response both to infection and vaccination. It has been designated as one of the select autoimmunity centers of excellence, and several of the seminal studies with regards to the role of infection causing autoimmunity has been done in this center, particularly with Epstein-Barr virus. We now try to postulate this simply age-old question with regards to which came first, the chicken or the egg. The hypothesis, overarching hypothesis for lupus is that by being able to characterize and understand the initial autoimmune responses to common autoantigens in lupus, we'll be able to understand the role of these autoantibodies in disease pathogenesis, establish etiological triggers for this dreaded disease, and find genetic pathways which predispose to these abnormal events. It has been reported in the landmark paper published in New England Journal in 2003 that autoantibody development has been established to be present before the clinical onset of SLE. And it has been described in the cohort that they are present many years before the culmination of SLE. So they tend to follow autoantibody specificity with regards to their end organ affectation with a predictable course. We now pose this question: what predisposed these supposedly healthy individuals to develop autoantibodies? So depicting lupus pathogenesis, we know that there are certain susceptible genes, and there will be an environmental genetic predisposition trigger, meaning there will be a gene to environment interaction that thereby promote the onset of autoantibody production. Ultimately, it will cause pathological injury to end organ like your kidneys, like your glomerulus in the kidneys. And ultimately, this patient will present to your clinic having fulfilled the current criteria for lupus. At this point, there have been heralded autoantibody production at a certain point in time before clinical disease. So the question is, would we be able to prevent this clinical disease if we're able to address this onset of autoimmunity through this autoantibody production? We tend to believe that not all are idiopathic and everyone must come from somewhere, including disease pathogenesis. So there are novel and landmark data with regards to Epstein-Barr virus and SLE that has been spurned out in OMRF and has been replicated in many centers worldwide. In this proof of concept model that we try to summarize all these published studies with regards to EBV, we've tried to present the model for development of SLE. We know that there's normal immune response among genetically susceptible individual, and there will be gene and environment interaction, particularly an infection with an ubiquitous organism that at some point in time, most of us will be exposed, like your EBV. This will generate antibodies to these ABV antigens, like your nuclear antigen, your viral capsid antigen, your early antigen. And in particular, the EBNA1 antigen will generate anti-EBNA1 or EBNA1 antibodies. This will promote an SLE pattern, particularly cross-reactivity to specific autoantibodies of lupus, like your SMB prime, as well as your Rho. So these anti-EBNA1 antibodies will generate cross-reactivity to the first epitope of Rho, the 60 kilodalton Rho, as well as the SMB prime. All of them will be propagated and perpetuated with an epitope spreading pattern that will occur along pathogenic autoimmunity, eventually promote clinical illness. These are the properties that we have enumerated that is expected for a pathogen like the common EBV leading or triggering to SLE. It precedes autoimmunity, it induces type 1 interferon response, it breaks tolerance, it has super antigen activity, it inhibits apoptosis of infected cells, as well as interferes with its own destruction, thereby breaking the tolerance, causing autoimmune disease. In the summer of this year, still during the current pandemic, several rheumatologists who are interested with the link between infection and autoimmunity gathered and came up with key questions. The first question was, does established autoimmunity predispose to severe COVID-19? And the next question was, can SARS-CoV-2 infection trigger de novo autoimmunity? In this molecular description of the etiopathogenesis and the pathomechanism for COVID-19 infection, we have seen how it has evolved through time and what have we learned so far. We know that there is the process of viral entry and replication, and several of these drugs, many are repurposed, are being looked into. For example, your hydroxychloroquine, for your convalescent plasma, all of them will act during the viral entry and replication. And then you have the antiviral immune response that primarily involve your interferon, particularly your type 1 interferon, important in antiviral immunity. Ultimately, you have the damage-associated molecular pattern that will promote further inflammation by inducing inflammation through interleukin-mediated autocrine and paracrine loops. You would see your inflammasomes, and all of them culminating to a cytokine storm with all these cytokines, tumor necrosis factor, interferons, and interleukins being acted upon in the body, ultimately causing end organ damage. And this end organ damage is primarily manifested in lungs, presenting with lung edema, hemophagocytosis, there's vascular leakage, and ultimately an unabated inflammation. As you notice, the blue bars will have several of these repurposed drugs, and some are developed specifically into COVID, looking into a role in preventing progression of your COVID-19 infection. So you have the JAK inhibitors, colchicine, eculizumab, and then the interleukins. Steroids is also part of this, particularly on the stage of cell activation, infiltration, and hyperinflammation. So we go back to this chicken or egg question. In this elegant and novel paper that includes the OMR group and led by Professor Chang, they were able to demonstrate among hospitalized patients in UPenn that autoantibodies are identified among half of these patients, but only less than 15% of healthy controls. The ANA are produced by 1 in 4 of these hospitalized COVID-19 patients. We know that the ANA is the primary autoantibody and used as a screening test for systemic autoimmune disease. And several of these heat maps were arranged, the protein microarrays, and have identified autoantibody targets among these hospitalized patients, meaning these are severe or to critical COVID-19 patients. And the serum autoantibodies among these COVID-19 patients recognize antigens targeted among rare connective tissue disease or autoimmune disease, and antigens associated with pathogenicity, as I would explain later. These autoantibodies are triggered by the infection to SARS-CoV-2 virus, and new onset IgG autoantibodies are temporarily associated with responses to your anti-SARS-CoV-2 IgG. So in this heat map, depicting a high prevalence of autoantibodies among these hospitalized COVID-19 patients, you would note that these are your COVID-19 patients, these are your healthy controls, and these are the prototypical autoimmune diseases based on the sera collected from Stanford and OMRF. You would see specific disease classification depending on the autoantibody profile in the x-axis. You have the scleroderma, myositis overlap, the Sjogren's and SLE, some GI endocrine autoantigens, those are with DNA-associated damages, those that are associated with inflammation as well as stress, interferons and interleukins. You would note that the responses are far greater among patients with COVID-19 infection. Furthermore, looking into the heat map using the 41-plex array of cytokines, chemokines, and other growth factors, you would see that the anti-cytokine antibodies would be highly present among patients with COVID-19 compared to the healthy controls as well as in the prototypical autoimmune disease. The mean fluorescent intensity will be higher for patients with COVID-19. There are also serum autoantibodies among COVID-19 patients that recognize antigens that are targeting rare connective tissue disease and antigens that are associated with pathogenicity. So what are those? So we're talking about antigens associated with autoimmune myositis and myocarditis. So namely, the MDA5, the troponin I, the troponin 1, the alpha myosin, the PL7, Jo1, and MI2. There will be RNA-containing antigens that are associated with systemic sclerosis, like your RPP25, and your fibrillarin, and your U11 and U12. There will also be antigens that may be pathogenic, like your C1q, your bactericidal permeable protein. So these are involved in vasculitis, as well as your beta-2 glycoprotein 1. So you would note that these autoantibodies would recognize this antigen and would have associations. So like in column B, you have the systemic sclerosis antigens, and there would be reaction among your COVID-19 patients versus your healthy controls. You would note that many of these patients with systemic sclerosis are predisposed to develop lung fibrosis or interstitial lung disease with progressive fibrosing phenotype, as seen with many patients with severe and critical COVID-19 pneumonia. So the autoantibodies are also triggered when you get infected by SARS-CoV-2. So these are the number of subjects in the y-axis and the number of antibodies per subject. The blue bar will be your autoantibodies, and the yellow bars are your anti-cytokine antibodies. So you would note that the patients with several of these autoantibody will have transient or fluctuating antibodies against these particular antigens, the MDA5, the PL7, PNR, tRNA synthetase, and the vasculitis antigen that I mentioned, the VPI. And then you would have examples of antigens that have been present at the time of infection and are unaffected during the SARS-CoV-2 infection, your SCL70, TPO, and the C1Q. And there will be anti-cytokine antibodies that are inducible, meaning when you get infected with the SARS-CoV-2 virus, you induce these anti-cytokine antibodies and reaction to the interferons, particularly inducible interferon epsilon, omega, and gamma. There will be additional examples like interleukin 17F, interleukin 22, and ACE2. So you would note their mean fluorescent intensity would be triggered by infection to SARS-CoV-2 infection. It has also been demonstrated that new onset autoantibodies correlate with anti-SARS-CoV-2 IgG response over time among recently infected patients who develop COVID-19. So these are your COVID-19 patients, and these are the colors would correspond to your mean fluorescent intensities. These are your healthy controls, and you would note in the x-axis this particular systemic autoimmune disease, scleroderma, myositis overlap syndrome, Sjogren's, those who are pathogenic along the line in the GI and endocrine system, DNA-associated inflammation or stress, autoantibodies, interferons, interleukins, and the anti-cytokine antibodies. You would note the stark difference of their MFI among COVID-19 patients versus the healthy controls. So we go back to these properties expected of a pathogen like EBV triggering SLE. Does this apply to a pathogen like your SARS-CoV-2 infection, causing this cytokine storm among severe and critical COVID-19 pneumonia? So several of the data with regards to these properties has been published through time in this course of the pandemic. So with regards to precedes autoimmunity, there are several case reports of patients developing classifiable autoimmune disease following SARS-CoV-2 infection. So these are some. When we talk about inducing type 1 interferon, SARS-CoV-2 does induce robust type 1 interferon response in a subset of patients, and some have been published. Now, with regards to breaking the tolerance, particularly inducing autoantibody production, in the paper that I've shown early on, as well as another one by Wang. How about superantigen activity? So the SARS-CoV-2 spike protein contains a superantigen motif, and patients with severe COVID-19 had this TCR repertoire response. With regards to inhibiting apoptosis of infected cells as well as interfering it with its own destruction, we have no evidence today. So looking into more specific with regards to interferons, is this the convergent pathway with lupus and COVID-19? Historically, we divide interferons either as type 1 and type 2. We have interferon alpha and interferon beta. Your type 2 would be your interferon gamma. We know in several of the in vitro and in vivo studies that SLE patients with active disease have elevated levels of interferon alpha in their serum. And there's predilection for more severe SLE if you have a high type 1 interferon production. And we also know that the type 1 is triggered as a normal event of the immune system if we want to protect our body from pathogens, particularly viruses. Thereby, the type 1 interferon is integral as an antiviral cellular response. What happened with COVID is that when you have severe COVID, you exhibit autoantibodies antagonizing your type 1 interferon immunity. So this is your interferon, and it binds to your interferon receptor, AB, the IFNAR1 and 2. Ultimately, this binding will promote interferon-stimulated genes, and these interferon-stimulated genes will have an antiviral immunity, thereby breaking or causing diminishing viral replication upon exposure of a virus in the cytoplasmic level. What happens with COVID-19 severe infection is that you develop these anti-interferon autoantibodies. Ultimately, there will be uncontrolled replication of the virus because their interferon-stimulated genes will be prevented. There will be hyperinflammation and ultimately end organ damage. There will be tissue damage. There's also this potential downstream mechanism of autoantibodies that were identified among patients with severe COVID-19 infection. So it has been documented and reported that in COVID-19 infection, you have the production of antiphospholipid antibodies and the neutrophil extracellular trap antibodies. So your antiphospholipid antibody will stimulate production of your nets, and there will be presence of your anti-nets antibody. And this will all activate your complements. And this complement activation will promote further thrombosis and fibrin formation. There will be also some degree of blocking of your interferon-stimulated genes brought about by your autoantibody, IgG autoantibody, that acts on your functional class gamma R2b receptors. There are also this potential mechanism of de novo autoimmunity among COVID-19 patients. So we have naive B cells, and during COVID-19 infection, the extrafollicular pathway predominates versus the germinal centers, which are the secondary lymphoid organs. The problem with this extrafollicular pathway is that you have more autoreactive B cells that are poorly regulated as opposed to those with germinal center, because germinal center had more checkpoints. With this extrafollicular pathway, you have a decreased levels of these checkpoints, particularly those with decreased IgD, CD27, CXR5, and CD21. You have an increased number of these double negative cells, and you increase further production, and you also decrease those germinal centers with tolerance checkpoints. Ultimately, these autoreactive B cells, which are double negative, will promote more of this plasma cell, causing more of this production of your autoreactive antibody secreting cells. We know that among patients with COVID-19, and in this atlas that was published and sponsored by NIH, that there is a predominance of immune cells, particularly macrophage, among patients who died or upon autopsy, particularly in their lungs, thereby proving an unchecked inflammation. And this lung tissue will contain unusually large number of fibroblast cells, causing fibrosis. So in short, what we see in the natural clinical course of many of these overlapping or many of the systemic autoimmune disease, particularly during their end stage or severe stage, like fibrosis, has been present in an unprecedented and accelerated phase when you get a COVID-19 infection. So in analogy, you have a potent microorganism, an infectious agent in the form of SARS-CoV-2, causing this damage at the end organs that were seen on many of the systemic autoimmune disease at a rapid phase and accelerated phase that is unprecedented. So do we have like a more potent infectious agent as opposed to a latent infection with an Epstein-Barr virus or even tuberculosis? These questions abound and is bound to be answered in the near future, hopefully. So just a few slides with regards to treatment and prevention paradigm shifts for severe to critical COVID-19 pneumonia. So going back to the elegant discourse of the clinical course of COVID-19, in several of these stages, a lot of the drugs that has been looked upon, and some have been debunked, were tried and tested for COVID-19 during the course of this pandemic. It is important to highlight that many of these drugs outpace drug development specifically for COVID-19. It's only now that we're looking into drugs, antiviral drugs specifically developed against SARS-CoV-2. But we have a lot of these repurposed drugs that were identified. Fortunately, now with the advent of artificial intelligence, there's a lot of AI algorithms and extrapolations from other disease entities, like what I mentioned earlier, those who develop macrophage activation or reactive hemophagocytosis secondary to chimeric antigen receptor therapy. Early in the pandemic, around March last year, the Philippine Rheumatology Association came up with a position statement due to the indiscriminate use of hydroxychloroquine. And what happened with this is that there will be a detriment among patients with lupus because of a run-up supply of hydroxychloroquine. A lot of these patients run the risk of disease flare during this period of time. It's a good thing that even during the first quarter of the pandemic, wherein there's still no standard of care, hydroxychloroquine was revoked. And at this point, the only one that is well established is a glucocorticoid that is a mainstay for the treatment of lupus. So glucocorticoid has been shown to cut or to decrease mortality by around 50% among patients who are oxygen requiring for COVID-19 pneumonia. Later this year, around September, the Philippine Rheumatology Association came up with a guidance statement with regards to this repurposed drug, just to highlight the fact that some of these repurposed drugs, for example, like tocilizumab, which has now been approved for several of these interstitial lung disease, for systemic sclerosis, and other overlap autoimmune disease, has utility for patients with COVID-19 pneumonia, particularly those who develop this lung fibrosis. We have to learn to live with COVID-19. The key here is that we have to downgrade the pandemic just to reduce it to an epidemic or just a mere disease outbreak. Because if we still maintain a pandemic scenario worldwide, we run the risk of burdening the healthcare system to its capacity. And we know that if we burden the healthcare system, it will compromise all patients who require chronic and acute care that are non-COVID. So we really need to learn to live with COVID, and the way to do it is to vaccinate our patients. To end, I remember during my fellowship, way back in 2007, seeing in person Yehuda Schonfield, he claimed that everything is autoimmune unless proven otherwise. And I saw him once again, around 3 years after, and he changed his tempo. He mentioned now that everything is infectious unless proven otherwise. I would just like to highlight the fact that we should not forget the host in treating this infection. Treating severe to critical COVID-19 and understanding now many of these pathomechanisms, it is definitely a multidisciplinary approach. I would like to thank Dr. Navarra for her vision, as well as her pioneering and trailblazing efforts. And thank you all for your attention.
Thank you very much for your kind invitation to participate at this Lupus Academy meeting, and especially for the possibility to talk on this complicated hypercoagulability conundrum that is the combination of COVID-19, thrombosis, and the antiphospholipid antibodies. These are my disclosures. And these are the learning objectives of this talk. I would like that you manage to recognize the clinical and subclinical thrombosis as important challenges in the management of patients with severe COVID-19. Also, to describe the options for the prophylaxis and treatment of thrombosis in patients with this condition, and to discuss the new trends in research on the pathophysiology of thrombosis in severe COVID-19, including the potential role of the antiphospholipid antibodies. Well, at this stage of the pandemic, everybody already knows that COVID-19, in addition to the initial viral response phase, in many cases presents also an autoimmune response, a host inflammatory response phase. And in some patients, this is accompanied by a terrible cytokine storm or a systemic inflammatory response syndrome, a syndrome that we, with Professor Schoenfield, coined the term, the very expressive term that this is a hyperferritinemic syndrome. But it was really a surprise, but we realized very soon that in addition to this systemic inflammatory response, there were many thromboses, arterial, venous, and also thrombosis in the microcirculation, complicating these patients. So it was very soon put in the list of clinical manifestations of the critical severe COVID-19 infections, in addition to the respiratory failure, to the septic shock, the multiple organ thrombosis that appear in some patients. And also that was accompanied by the classic laboratory features of this condition, high levels of ferritin, high levels of the D-dimer, LDH, troponins, and so on. And a lot of literature appeared linking this COVID-19 with microangiopathy, hemostatic abnormalities, also complement activation. Actually, this means that we are entering in a very complicated issue, which is hemostasis. And if we put together this complicated issue of hemostasis plus COVID-19, we are certainly in a hypercoagulability conundrum. And in just a few months, many studies have appeared, many publications have appeared, and it's really a very complicated issue. It's full of literature, articles trying to disclose some information, some clear information among this terrible conundrum. Starting by pathophysiology, many mechanisms of action, of production of these thrombosis have been implicated, starting by endotheliopathy and vasculopathy, through platelet activation, complement activation, till also the antiphospholipid antibodies. For instance, the group of George Goshua stressed the importance of this endotheliopathy in COVID-19 patients. Also, hypercoagulability and fibrinolysis abnormality have been found. Platelet activation also is another mechanism of production of thrombosis that has been involved in some of these studies, as well as complement activation. Or netosis. Netosis is a mechanism of production of immunothrombosis that has received a lot of attention recently, and also in the field of COVID-19. As well as neutrophil activation, for instance, or also the cytokine storm. Many cytokines have been implied in the pathogenesis of this immune thrombosis. ADAMS13, one of the molecules involved in thrombotic thrombocytopenic purpura, has been also implied in the pathogenesis of this COVID-19 thrombosis. And of course, the antiphospholipid antibodies. If we are facing patients who present with multiple organ involvement, with systemic inflammatory response syndrome, with multiple thrombosis, It really looks like the catastrophic variant of the antiphospholipid syndrome that is a terrible variant that we described with Ron Asherson in the early 90s of patients who presented multiple organ thrombosis in a short period of time, leading to multiple organ failure, and that the thrombosis were mainly in the microcirculation. Well, these patients with COVID-19, severe COVID-19 and multiple thrombosis, in some way resemble this catastrophic antiphospholipid syndrome. And that's the reason that the antiphospholipid antibodies were looked for very soon at the beginning of the pandemic. And they were found. Some authors already described early in the pandemic the presence of antiphospholipid antibodies in patients with severe COVID infection. As you know, our group is doing a lot of research on the field of antiphospholipid antibodies, and we decided also to analyze the potential role of the antiphospholipid antibodies in the thrombosis associated to COVID-19. And we performed this very nice study that we have just published, and that I will just summarize in the next few slides. We, at the beginning of this pandemic, we managed to collect 474 COVID-19 hospitalized patients, and to collect the data and the serum from these patients, and to also we collected a control group of 131 patients. And we analyzed the levels of antiphospholipid antibodies in these patients. And while for the classic antiphospholipid antibodies, that's lupus anticoagulant, anticardiolipin antibodies, and then the IgG and IgM, anti-beta-2 glycoprotein 1 antibodies, the prevalence of these antibodies was similar both in patients with COVID-19 and in the control group. It was around 4 to 5%. And the same for antiphosphatidyl-prothrombin antibodies. However, the presence of, or the prevalence of IgA, anti-beta-2 glycoprotein 1, was clearly higher in patients with COVID-19. It was 15% as compared to 6.9% in the control group. However, we analyzed if these antibodies were associated with thrombosis in these patients with COVID-19. And certainly no association at all between these antiphospholipid antibodies and the thrombosis that presented some of these COVID-19 patients. And there was no association with thrombosis. And also, there was no association with the prognosis of the patient, with the survival of the hospital discharge. So we can say that COVID-19 thrombosis mimics in some way the antiphospholipid syndrome, even the catastrophic antiphospholipid syndrome, but it is not clearly an antiphospholipid syndrome. However, very interestingly, what we did in addition in this study was to compare the levels of the beta-2 glycoprotein 1. You know, the beta-2 glycoprotein 1 is the cofactor of the antiphospholipid antibodies. Well, we compared the levels of this cofactor among the three groups, among the COVID-19 patients, also the control group, and also blood donors from our blood bank. And very interesting, as you can see in this slide, much lower levels of beta-2 glycoprotein 1 levels were detected in COVID-19 patients as compared with the blood donors or with the control group that we analyzed in this study. So Probably what happens is in these patients with COVID-19 is something that already Pierluigi Meroni, Angela Tincani, Laura Andreoli already hypothesized a few years ago, is that increased apoptosis leads to the consumption of beta-2 glycoprotein 1. And this consumption of beta-2 glycoprotein 1, these decreased levels of beta-2 glycoprotein 1 also leads to thrombosis. So this journey, this pathway between infection and thrombosis in COVID-19 is probably mediated by the hyperinflammation, the systemic inflammatory response that appears in these patients, the increased apoptosis that appears in these patients, also some level of hyalinization, and also hypoxia, thus leading to thrombus formation. But this happens just in some patients. Not all patients certainly present this. Probably it is required some, let's say, thrombotic phenotype. And now let's see the clinical features of this thrombosis associated to COVID-19. And what we realize very soon is that this COVID-19 coagulopathy shares many features with the other microangiopathies, and also many laboratory features, increased levels of ferritin, D-dimer, LDH, troponin, and so on. And as you can see in this table that was published by John Merrill and Doru Kerkanen and other colleagues, that comparing the features, the clinical and laboratory features of COVID-19 thrombosis with the other microangiopathies, with catastrophic antiphospholipid syndrome, with hemolytic uremic syndrome, atypical hemolytic uremic syndrome, thrombotic thrombocytopenia purpura, disseminated intravascular coagulation, you can see that they share many similarities. And this leads to probably what is more important, is the treatment. And as these authors already stress, these thrombotic events in patients with COVID-19 has certainly treatment implications. And the main treatment implications is that we need the use of heparin. And heparin is very important because it is not just an anticoagulant. We already know from previous studies that heparin has much more effects than just an anticoagulant. It inhibits inflammations, it inhibits the platelet activations, it inhibits neutrophil recruitment, it inhibits angiogenesis. So many of the pathophysiologic mechanisms that we show you at the beginning of this talk that have been implied in COVID-19 thrombosis certainly are inhibited by heparin. So heparin was quite soon used in patients with this thrombosis, and this study coming from China certainly confirmed that the use of heparin was associated with a decreased mortality in severe COVID-19 patients. And that's the reason that also very soon the International Society of Thrombosis and Hemostasis produced these guidelines for the management of coagulopathy in COVID-19 patients that for sure have saved many lives. So we can conclude that venous, arterial, and microcirculation thrombosis are common findings in patients with severe COVID-19, that multiple mechanisms have been involved in the pathogenesis of thrombosis associated to COVID-19, and that the antiphospholipid antibody beta-2 glycoprotein 1 pathway is most probably involved in some way in the pathogenesis of thrombosis associated to COVID-19. And for sure, the prompt use of anticoagulant therapy, heparin, of course, is of paramount importance in patients with severe COVID-19. Thank you very much for your attention.
It's a great pleasure to be here, and I'd like to thank the organizing committee, and particularly Sandra, for the kind invitation to talk about the impact of distinct therapies on antibody response to SARS-CoV-2 vaccine in systemic lupus erythematosus. This study was performed at the Division of Rheumatology Medical School of the University of São Paulo, Brazil. I have no conflict of interest. The study setting of this study is Brazil, a country with more than 20 million cases of SARS-CoV-2 infection since its first confirmed case on February 27, 2020. Unfortunately, Brazil has more than 600,000 deaths reported until October 2021, with a lethality rate of 2.8%, the fifth highest lethality rate in the world. Coronavac vaccine, as you all know, is a SARS-CoV-2 inactivated vaccine. It was approved for emergency use in several countries, including some most populated ones in both here, China, Hong Kong, Indonesia, and Brazil, and also in Chile and Turkey. Nowadays, Coronavac accounts for 1/3 of all administered vaccine in Brazil. Coronavac vaccine effectiveness was demonstrated in an elegant work published in New England Journal of Medicine. This work was a prospective national cohort from Chile with 10.2 million persons, and they have demonstrated the protective effect of this vaccine for hospitalization, 87.5%, ICU admission, 90.3%, and COVID-related deaths, 86.3%. The objective of this study was to evaluate in more than 200 naive lupus patients and 58 naive age and sex balance control group immunogenicity, influence of therapy in vaccine response, safety, and incident cases. The study design was a prospective control trial, which was included in a large phase 4 study. For this study, we selected consecutive lupus patients 18 years old or older from the outpatient rheumatology clinics. Controls were balanced for age and sex using an Excel program plus minus 5 years difference. None of the controls had ARDs or were under immunosuppressive therapy. We have a long list of exclusion criteria illustrated in this slide, but I would like to focus on the bold text in which we excluded pre-exposed individuals. This is very important. We exclude all individuals with pre-vaccination positive COVID-19 serology or non-positivity. This was very important to define more accurately the vaccine-induced immune response. Vaccination protocol illustrated in this slide include 2-dose schedule of COVID-19, 20 days apart, D0 and D21. Blood collection was performed at D0, D28, and D69. And for incident case, we determined 2 time points. The first one was named incomplete vaccine response, D0 up to 10 days post-second dose, D38. And complete vaccination response with D39 to D69, not D79. Immunogenicity evaluation had as primary outcome at D69 seroconversion rates, IgG, and NAb positivity, neutralizing antibody positivities. We had several other secondary outcomes, including immunogenicity parameters, influence of therapy in vaccine response, safety, and incident cases. The methodology to detect anti-SARS-CoV-2 S1, S2 IgG antibodies, seroconversion, and the neutralization antibodies are illustrated in this slide. Vaccine adverse events, an incident case of COVID-19 was performed in 2 in-person visits at D28 and D69, using a standardized diary with local and systemic events, in addition to telephone, smartphone, instant message, and email contacts. All symptomatic cases were tested using RT-PCR for SARS-CoV-2. Statistical analysis was the appropriate one, illustrated in this slide, and the significance was set as less than 0.05. Baseline characteristic of patients with lupus and control groups is illustrated in this slide. We have here 232 lupus patients and 58 controls. And this table is very important because it includes at least 2 very important parameters for vaccine response, age and sex. And we can observe here that the 3 parameters illustrate age, sex, and race. They were comparable in these 2 groups. This is important because these are factors that influence vaccine response. We also evaluate comorbidities in these 2 groups, and this is also important because these comorbidities are risk factors for COVID infection. We can observe that both groups have a high incidence of several comorbidities, but the only comorbidity that was more frequent in lupus patients was systemic arterial hypertension, 44% versus almost 20% in the control group. And we have now the current therapies at baseline. More than half of the patients were under prednisone, but 20% approximately were under high dose greater than 20 milligrams, but the median dose was only 5 milligrams per day. More than 80% of our patients were under hydroxychloroquine, and I would like to call your attention that 75% of our patients were under immunosuppressive therapy since they are tertiary center patients. And belimumab was used in 14% of the patients. A more detailed analysis of immunosuppressive therapy revealed that mycophenolate mofetil was the most widely used immunosuppressive therapy, 1/3 of the patients. Azathioprine and methotrexate were lower than mycophenolate, but the other drugs were less frequently used. In this slide, we have seroconversion rates at 2 time points. After the first dose, D28, and after the second dose, D69. We will focus on D69. We can observe that lupus patients have 70% seroconversion rates. And this is a moderate response. Just as a comparison, we have performed previously a study with H1N1 vaccine a few years ago. And these patients, the same group of patients, had 64% response for H1N1 vaccine. So it's a moderate response, but it was lower than 98% observed for the control group. Another important message of this slide is the fact that vaccine response after the first dose is very low. So for this vaccine, it's essential to have the second dose to achieve the maximum response. Now we have illustrated geometric mean times in the same time points. After the first dose, D28, after the second dose, D69. And we have here that the geometric mean titer for lupus patient is low to moderate, approximately 30, and it's much lower than the observed for the control group, which is 77%. And again, we reinforce that at D28 after first dose, the response, the geometric mean titer is very low for patients and controls. So for this vaccine, second dose is essential. We next evaluating neutralizing positivity and neutralizing activity. And we have this slide, the D69, the second dose response for non-positivity and neutralizing activity. For non-positivity, lupus patients have moderate response, almost 62%, but lower than observed in the control groups, 85%. Interestingly, neutralizing activity at D69 was similar in lupus patients and controls. Sorry. Next, we have the same response, neutralizing positivity and neutralizing activity at D28. We can observe here that after the first dose, neutralizing antibody positivity is low in lupus patients and controls. And neutralizing activity, interestingly, is already moderate for patients in control. We evaluate adverse events after the first dose. And we have here illustrated that they were comparable among patients and controls. We did not have any moderate or severe adverse events, only mild. And most, 40 to 55% of lupus patients in control have no symptoms. Local reactions occur more in less than 1/3 of the patients in controls, and systemic reactions were more often observed across 40% in both groups, and they were comparable. Again, after the second dose, we did not have severe or moderate events, only mild, and again, they were similar in patients in control, no symptoms, local reactions, systemic reactions. The next investigation we perform is to define risk factors for vaccine response. And now in this first part, we evaluate risk factor affecting seroconversion. And we can observe here, when we consider only age over 60 years old, female sex, and SLEDA, they did not have a deleterious effect on seroconversion rates. For age, it's probably due to the fact that we have a small representation of patients older than 60 years old. For non-positivity at D69, again, we have not observed any influence of age over 60 years old, female sex, or SLEDA disease activity. The odds ratio for seroconversion, so we're going back to seroconversion, and we analyze the influence of drugs. This is very important because we have very interesting finding regarding drugs for vaccine response. The first interesting finding is the fact that the hydroxychloroquine more than double the chances of vaccine response, 2.4. Whereas prednisone decreased almost 80% the chances of vaccine response, and the cutoff is low. It's equals to or more than 10 milligrams per day. For other drugs, seroconversion, immunosuppression, we can observe here that immunosuppressive therapy has a major impact in vaccine response, and MMF is the most important drug. Other immunosuppressive therapy did not have deleterious effects, as well as belimumab also did not have a deleterious effect. We next investigate if the association of hydroxychloroquine with of patients taking immunosuppressive therapy and glucocorticoid had a distinct response from those taking only immunosuppressive therapy and glucocorticoid. And interestingly, we observed that we had a more than double chances of a response in patients that were taking hydroxychloroquine plus immunosuppressive therapy. We had attendance, so it's not, the numbers is small and it's not conclusive. The odds ratio for NAB, now we are working on neutralizing antibody. What are the drugs that affect NAB positivity? And we have again that only prednisone decreased 70% the chances of NAB positivity in this population. Immunosuppressive therapy and MMF were the same drugs that affect seroconversion, and now they affect also neutralizing antibodies, so are the major important factors as deleterious factors for vaccine response. We perform a multiple logistic regression analysis at the 69, and we can observe here that age had a minor impact. We have a balanced age and we have a range of good response, 40 years old. Prednisone and MMF had a major effect, very important, 80% more so, deleterious effects in patients with lupus patients. With regard to neutralizing antibodies, again, prednisone and MMF had a major impact, not as much as seroconversion, but also very important impact, almost 60% impact on vaccine response with the use of this drug. We next evaluate incident cases. So let me just explain the time points we have here. D0 is first dose, D28 is second dose, and then 10 days after, we concluded a period we called incomplete vaccine response, first dose to 10 days after the second dose. Then we had a period of complete vaccine response, D38 to D69. In the first period of incomplete vaccine response, we have 11 breakthrough cases. And the second period, we had no case of COVID. Interestingly, exactly in the same period of complete vaccine response, we had no cases, but the city of São Paulo was having the second peak with a 45% increase in case of São Paulo. So while the city was increasing, our population of immunosuppressed patients was decreasing in number of cases. We also evaluated the same time period hospitalization. We had one during the incomplete vaccine response period and none in the second period. And finally, before I close, I would like to discuss with you immunogenicity of Coronavac versus other vaccines. We have two major, most important studies. One is from our group, I'm presenting here, and the other is from USA, New York. This study from New York used mRNA and adenovirus vaccine. We used Coronavac. We had 232 patients, they had 90. We had 58 controls, they had 20. And importantly, they have not excluded seropositive patients before vaccination. So this is a very important parameter, not to exclude antibody production, which is not related to vaccine. So they have not excluded, so their data may be a little overestimated. And both studies were age controlled. Another important aspect when we compare these two studies is the fact that they are not comparing regarding drugs. We have 75% of our patients under immunosuppressive therapy, whereas for theirs was 42%. And glucocorticoid use was used by 55%, almost 55% of our population, and 30% of theirs. Biological therapy, they have a higher frequency, 22% versus 14%. And the final result for seroconversion rate in our study was for naive patient was 70.2%. But if we include seropositive patients, we had 78% and they have 71%. So in conclusion, what we have is a very similar seroconversion rate, if anything, a little bit higher with coronavac since we did not include seropositive patients. With that, we conclude that coronavac for ARD patient has a moderate immunogenicity, 7.4% for naive and 78% seroconversion, including pre-exposure, although lower than controls. Our data suggests that vaccine type may be not a major factor for immunogenicity in lupus patients. They seem to be similar with these three vaccines. We identified specifically for lupus patients that glucocorticoid and MMF are the most relevant factors to impair immunogenicity in lupus patients. And vaccine, we have demonstrated that vaccine is safe. Finally, I would like to say that we need urgently new strategy to improve response in patients that do not respond to the vaccine. It may be a third dose and may be a temporary suspension. Thank you very much.
me?
Yeah.
Input, no problem. It's the out. Okay.
Okay. Okay. Is everyone hearing me now?
Yes.
What about the participants? Are you hearing me now? Okay.
Output, yes.
Okay, let me just go through the first slide again. As I was saying, we'd like to thank our speakers, excellent lectures, wherein Ivan talked about convergent pathways, and he spoke on COVID-19 clinical course from viral response phase and then moving on into the host inflammatory response phase, wherein we have the hyperinflammation going on. And here, very elaborately on the viral entry and replications, in other words, your body's immune response to the virus itself, and later on proceeding to a hyperinflammatory response characterized by this with convergent and shared pathways in COVID-19 and lupus, in terms particularly focusing on interferons. Then this is also substantiated by the fact that we have a high prevalence of autoantibodies in hospitalized, and these are autoantibodies in hospitalized COVID-19 patients. Next, we have Professor Ricard Cervera speak on the hypercoagulability conundrum, focusing on COVID-19 and its relationship to thrombosis and antiphospholipid antibodies. And here he showed that these are the clinical manifestations in the spectrum of COVID-19 infection, wherein we have the critical phase showing many of these thromboembolic events happening with your increase in ferritin, D-dimer, LDH, troponin, and as well as leukopenia. And here are now the pathophysiology of thrombosis in COVID-19 infection. So you have endotheliopathy, hypercoagulability, platelet activation, complement activation, netosis, neutrophil activation, cytokine storm, Adams 13, as well as antiphospholipid antibodies. And he did say that there are many features with others shared with other microangiopathies like TMA, CRS, and DIC with your COVID-19 coagulopathy, but particularly antiphospholipid syndrome, relevant to us rheumatologists. But he went on to say that there's actually no association of APL thrombosis because the presence of APL does not affect the prognosis of patients. Indeed, COVID-19 may mimic APS, but it is clearly not APS. Now, to elaborate more on the clinical issues and practice points, particularly focusing on anticoagulation for severe COVID-19, let's now call on Leonid Zamora, a young rheumatologist, assistant professor in medicine, UST Faculty of Medicine and Surgery, and assistant training officer of rheumatology at UST Hospital. He's currently completing master's studies in molecular medicine. Leonid?
Thank you and good morning, Professor Navarra, and thank you and good morning to everyone who's joining us this morning. So the key points in thrombosis in COVID-19, as Professor Ricard Cervera nicely elucidated the evidences that COVID-19 coagulopathy has multiple mechanisms and may even involve the anti-beta-2-glycoprotein 1. However, the presence of these new antiphospholipid antibodies is shown that there's no association with thrombosis and does not affect the prognosis of patients with COVID-19. And he nicely showed that COVID-19 coagulopathy may mimic the APS, but really not APS and not fulfilling their criteria for APS. However, patients who are hospitalized because of COVID-19 needs prompt use of anticoagulant therapy, primarily of heparin. And this is of paramount importance in patients with severe COVID-19 as they are at increased risk of thromboembolic events and poor outcomes. And so the Philippine Society of the Vascular Medicine updated their guidance on the role of anticoagulation in COVID-19 patients. And this subsets of patients who are hospitalized because of COVID-19, they categorize the patients who will benefit with anticoagulation. And you have here mild clinical syndromes of COVID-19 patients, but of high risk for VTE, as seen with a PADUA score of more than or equal to 4. Those patients as well with mild clinical syndromes with presence of high D-dimer levels of more than 1,500 milligrams per ml may benefit as well with anticoagulation. Those pregnant and postpartum patients, critically ill or requiring ICU level of care, those patients requiring organ support such as use of non-rebreathing mask, high-flow nasal cannula, non-invasive and invasive mechanical ventilation, and or vasopressors may benefit and will benefit with anticoagulation. And at the end of the spectrum would be the moderate or severe patients, but not requiring ICU level of care, and those patients who have confirmed VTE or high suspicion index of VTE. And so just to elucidate more on what this PADWA classification or prediction score is, these are the different risk factors that are included in the scoring system. You have your active cancer as defined as local or distant metastasis and with chemotherapy or radiation in the previous 6 months. Previous history of your VTEs, reduced mobility as defined as anticipated bed rest with bathroom privileges for at least 3 days, known thrombophilic conditions, which includes your defects in antithrombin, protein C or S, factor V laden, and mutations in your prothrombin alleles or presence of antiphospholipid syndrome, recent trauma or surgery, elderly patients more than 70 years old, heart and or respiratory failure, acute MI or ischemic stroke, acute infection, and or rheumatologic disorder. In this case, would be SLE patients, ongoing hormonal therapy, and obesity. So you have high risk for VTE if your PADWA score is 4 or more, and prophylaxis among these patients is highly suggested. And so going into the different categories of patients, your mild clinical syndromes, D-dimer, more than 1,500 nanograms per ml, pregnant postpartum patients, critically ill, or those requiring ICU level of care, they recommended a standard dose of thromboprophylaxis among these subsets of patients. However, in patients with moderate or severe COVID-19, but not requiring ICU level care, or those patients who have confirmed VTE or high index of suspicion for VTE, they may receive therapeutic doses of your anticoagulation. In terms of extending our thromboprophylaxis for our patients who are for discharge, so before sending them home, you have to assess the risk or bleeding risk factors for this patient. So if any of the following is present in your patient, such as active gastroduodenal ulcer, major surgery trauma within the past 4 weeks, history of bleeding within the 3 months, low creatinine clearance of less than 13 mL per minute, pregnancy, on dual antiplatelet therapy or on clopidogrel, low platelet counts of less than 75 with known coagulopathy or persistent INR of more than 1.5, or presence of bronchiectasis, pulmonary cavitation, active cancer, or severe renal or hepatic disease, then there is no requirement to extend your thromboprophylaxis post-discharge. However, if none of this leading risk factor is present, then you have to perform your VTE risk factor assessment prior to discharge. And you can do this by using a modified improved VTE risk score or your PADWA VTE risk score. So if you have a moderate modified improved VTE risk score of 2 to 3 or a PADWA VTE score of 4 or more, then you can give or extend your thromboprophylaxis for a total of 7 to 14 days with the following medications: enoxaparin, your unfractionated heparin, fundaparinux, and rivaroxaban. However, for patients who have high modified improved VTE risk score of more than 3 or moderate risk scores of 2 to 3 with an elevated D-dimer, the recommendation is to give your thromboprophylaxis for a total of 35 days with your rivaroxaban 10 milligrams once a day. And looking closely into what this modified improved VTE risk score is, these are the different risk factors included in the scoring system. You have your previous VTE, thrombophilic conditions, those patients with current lower limb paralysis or paresis, those patients with cancer, immobilization, on ICU or CCU stay, or age more than 60 years old. And you can see here that you are at high risk. Your modified improved VTE score is more than 4 or more, or you have moderate VTE score of 2 to 3 with an elevated D-dimer of more than twice the upper limit of normal. And just to show you the different recommended standard dose prophylaxis for your enoxaparin, for your unfractionated heparin, and fundaparinux with recommended renal adjustments for normal individuals and for obese patients. And of course, the recommended therapeutic dose for anticoagulation, again, for your enoxaparin, unfractionated heparin, and fundaparinux with renal adjustment for obese patients more than 120 kilograms, and for those obese patients with weight of more than 150 kilograms. So all in all, I think important practice points in terms of anticoagulation for COVID-19 patients, next slide please, Doctor, would be to initiate prophylactic anticoagulation in all hospitalized, moderate to critically ill COVID-19 patients, and to consider thromboprophylaxis for mild COVID-19 patients if they do have moderate to high risk of developing VTEs. Your therapeutic dose thromboprophylaxis should be considered for moderate to severely ill COVID-19 hospitalized patients who do not require organ support if risk of bleeding is low, with confirmed, or those patients with confirmed or high suspicion of VTE. Routine assessment of your VTE risk and bleeding risk prior to discharge in all patients should be done before safely recommending post-discharge thromboprophylaxis. Professor Navarra?
Thank you. Thank you, Dr. Zamora, for that. Very nice and clear. And we now do know that at this point, we have the burning questions on immunization. And the presentation, the elegant presentation of Professor Bonfa, illustrating their experience in Brazil on the impact of distinct therapies on antibody response to SARS-CoV-2 vaccine, it particularly in lupus, is relevant in our presentation today. And to further bring that down to the bedside, to our actual patients, there are certain, aside from the burning questions on immunizations, we have that particularly useful for us in patients with, or relevant to us when we deal with patients with systemic lupus erythematosus. But before we ask Eloisa to elaborate on this, let's ask Associate Professor Maria Rona Bergantin to just give us some of the immunization FAQs, or frequently asked questions. Dr. Bergantin is the Chief of Infectious Diseases at the University of Santo Tomas Faculty of Medicine and Surgery, and is an expert on virology.
Thank you very much, Professor Navarra, and good morning, everyone. Before I proceed with the first question, and allow me to tell the audience that as of November 17, there are 159 candidate vaccines for COVID, and there are already 509 vaccine trials, which are being conducted in 60 countries. So there are already 24 COVID vaccines which have been approved, and 8 of them are already under the WHO emergency use listing. And so that brings us, how do these COVID-19 vaccine works? So in this slide, you're going to see that if we're going to look into the kind of vaccines that we have right now pertaining to the COVID virus vaccines, we have 2 types. If we have the whole virus vaccines, which can be the inactivated, and this is typically what is the platform for your CoronaVac, which I think Professor Bonfa has been using in Brazil. We don't have yet live attenuated vaccines which have been approved, but I think there are already trials going on in this. And which brings us to the next kinds, which are the component viral vaccines. So we have protein subunit vaccines, which contain only purified viral protein. So the significant ones which we'll look into for SARS-CoV-2 will be the spike protein, because we very well know that the spike protein is the one which is highly immunogenic. we also have trials ongoing for your virus-like particles. So you will have here the viral proteins, which of course are being utilized, but they do not contain the genetic material. And the more common ones that we do get to have in the market are the ones which contain the RNA or the DNA. And of course, the RNA-based vaccines, which we have widely available, will be our Pfizer and the Moderna, and they contain the viral genetic materials, which, of course, we very well know when we talk about viral genetic materials, they are the ones which give our body instructions to create the proteins, which causes um, uh, immune responses to our body. And then we also have platforms which will include the viral proteins which are incorporated or encapsulated in a non-replicating viral vector or a replicating viral vector vaccine. So when we talk of these viral vector vaccines, as I have mentioned earlier on, incorporated inside the structure of the other viral vector is the presence of your genetic materials for COVID-19. At present, none of the viral vaccines that we have, whether the whole virus vaccines or the viral component vaccines, are of the live kind. So often the question that is asked, which I often say, is that is there a risk that I'm going to contract COVID if I have been vaccinated? So no, the answer is definitely no. You don't get COVID-19 infection after receiving the vaccines because none of our present COVID vaccines are of the live attenuated kind. And then, which brings us to the next question, which COVID-19 vaccine is recommended for me? So coming from the recommendations of the American College of Rheumatology, so those with rheumatic and musculoskeletal diseases and those with autoimmune inflammatory rheumatic diseases patients should receive only COVID-19 vaccinations, which are of course consistent with age restrictions in your specific country, and of course with your emergency use approval or even FDA approval. So for those patients who have not yet been vaccinated, often it is recommended that the mRNA vaccines be given. So this is a choice over the single dose Johnson and Johnson vaccine, but there is no specific preference as to which type of mRNA vaccine should be given. So which vaccine is recommended as part of that? So either Pfizer or Moderna RNA vaccine should be given. And even if there will be some non-serious adverse reaction associated with the first dose of the vaccine, then the patient can still continue with the receipt of the second dose of the vaccine. And this should be in accordance to the guidelines from the CDC. Now, will the medications that a person with lupus is receiving interfere with COVID-19 vaccines? So in the table that we have here are the list of some of the medications which are currently using for our lupus patients. So with exception to hydroxychloroquine, where there are no modifications to either immunomodulatory therapy or vaccine timing, when we talk about abatacept, whether it's IV or subcutaneous dosing, the timing of the vaccination should be dosed depending on the dosage of your or schedule of the abatacept. So for IV abatacept, the vaccine timing should occur at least 1 week prior to the next dose of IV abatacept. But if the person or if the patient will be receiving the subcutaneous form, it is advised that the dosage of abatacept subcutaneous should be withheld for 1 to 2 weeks after each COVID vaccine dose. Of course, if the disease activity will allow this. Now, with regards to the utility of acetaminophen or other NSAIDs that we're often using, well, assuming that the disease is stable, we don't need to give these medications 24 hours prior to the vaccination. But post-vaccination, if the patient, let's say, develops fever, then we can give this at any time. Similar to abatacept sub-Q, or whenever a patient is receiving belimumab, then we have to withhold the medication for 1 to 2 weeks after a dosing of your COVID-19 vaccine. So the ACR task force did not reach any consensus whether to interrupt or continue with a vaccine dosing if the patient is receiving your tumor necrosis factor inhibitor, your IL-6 receptor, your IL-1 receptor, IL-17, interleukin 12 and 22, and interleukin 23, and other cytokine inhibitors. So I think at this point in time, you have to discuss with your healthcare provider. Now, with the cyclophosphamide intravenous medications, so you have to time the administration so that it will occur approximately 1 week after each vaccine dose, of course, when feasible. With regards to the rituximab or other CD20 B cell depleting agents, then you have to discuss this again with your healthcare provider with regards to the optimal timing of the dosing and the vaccination. With regards to all other conventional and targeted immunomodulatory or immunosuppressive medications, which are not included in the list above, then you have to hold for 1 week after each COVID vaccine. This is, of course, granted that the disease activity will allow. Take note that with all these medications that our patient is receiving, there has really been proofs that the immune response is blunted for these patients who have received COVID-19 vaccine. So its effect in the duration as well as the magnitude is really affected. Now, can the COVID-19 vaccine cause my lupus to flare? There has been a theoretical risk that for our autoimmune inflammatory rheumatic diseases, there could be worsening following COVID-19 vaccinations. But however, for those patients who have rheumatic and musculoskeletal disease, the risk, the benefit outweighs the potential risk for the new onset autoimmunity. Now, how about those patients who have multiple allergies? Is it safe to receive COVID-19 vaccines? There are no known contraindications there are no known additional contraindications to receiving COVID-19 vaccines for our autoimmune inflammatory rheumatic disease patients, unless there are any of the components in the vaccines which the person is allergic to. Now, for those individuals who have been vaccinated for COVID-19, do we still need to give a booster shot? The answer is a resounding yes. Okay, so for those who have been given the 2-dose mRNA series, or those who have been given the 1-dose Johnson & Johnson vaccine, a supplemental COVID-19 vaccine is recommended at least 28 days after the completion of the priming series. Whether for those patients receiving any immunosuppressive or immunomodulatory drugs other than your hydroxychloroquine monotherapy. Now, for those patients who previously completed your COVID-19 mRNA vaccine, so series that are 2 doses or your single dose J&J vaccine, who are receiving supplemental booster dose, it is recommended that we receive or that they be given the messenger RNA type of vaccine. So for those patients who are having current lupus activity, can they still receive the vaccine? The answer is except for those patients who have life-threatening illnesses. Of course, for those who are admitted in the intensive care unit or critical care unit, the COVID-19 vaccine could be administered as soon as possible for those whom it's recommended, irrespective of the disease activity and, of course, the disease severity. Now, this is not just a question coming from lupus patients, but more so even in the general population. Can we stop wearing masks after receiving COVID-19 vaccine? The answer, of course, is no. We still have to continue to maintain our health protocols. Of course, important here is you're wearing or donning on our face mask, observing the appropriate physical distancing, and of course, hand washing to prevent still the further spread of our virus. And I think that should occur until the WHO declares that this pandemic is over. Thank you very much, Professor Navarra.
Thank you, Dr. Berganti. That was great. Very, very engaging. Let's now have a few insights from the pediatric rheumatologist standpoint. And incidentally, she's also almost finishing her master's studies in public health epidemiology. Dr. Collante, our pediatric rheumatologist. Any further insights on this?
Yes, thank you, Dr. Navarra. A good Saturday morning of learning to our participants. And thank you, Dr. Navarra, for sharing a few minutes of this activity with pediatrics. Yes, children and teens should be vaccinated for COVID-19 because even though they are known to have a low risk of being severely ill with COVID-19 compared to adults, children can still be infected. They can still get very sick from it. They can have both short-term and long-term complications from COVID. And of course, they can spread COVID-19 to others. So in the Philippines, as of October 14, 2021, there were around 120,000 cases in the less than 10-year-old group and around 200,000 in the 10 to 19 years old group. Children with underlying medical conditions, such as those with rheumatic diseases, may be more at risk of severe illness from COVID-19 compared with children without medical conditions. And one of the more serious complications of COVID-19 in children is the multi-system inflammatory syndrome, which is also called MIS-C. There are the general principles of vaccination applies to the pediatric population. And thank you, Dr. Bergantin, for covering it in your talk. Of course, there are some peculiarities in children related to dose and possible side effects. And I would like to just emphasize on those several points. So which vaccines are being given to pediatric patients? Pfizer is being used in 24 countries for the 12 to 17 age group, and Moderna in 13 countries. In the Philippines, the FDA has issued EUA for Pfizer and Moderna to be given to children 12 to 17 years old based on the evidence review of the OHH-TAC, showing that both vaccines are effective, safe, affordable, and feasible. The same vaccines are recommended for children with well-controlled rheumatic diseases. Pfizer dose for 12 to 17 years old is the same as in adults. In 5 to 11 years old, in the future, when we are able to give it to them, it is lower, 10 micrograms per dose. Same two dose with a 3-week interval. There isn't any vaccine yet authorized to be given to children 4 years old and below, and there are no recommendations yet regarding boosters. In terms of side effects, the most common side effects from the two vaccines are local reactions and mild systemic reactions. An uncommon vaccine reaction being reported is myocarditis, which is with Moderna having a slightly higher risk compared to Pfizer. And intake of medications in children with well-controlled rheumatic diseases should not interfere with the declared efficacy and safety of COVID vaccines. Although there is really a theoretical risk of the vaccine causing flare, and on the same line, children who are in flare may receive COVID vaccine as soon as the rheumatic disease is controlled. And in terms of allergies, children with multiple allergies can receive the recommended COVID-19 vaccines with precautions as with adults with allergies. In the vaccination sites that I have been helping with, we have standby pediatrics and anesthesiologists for respiratory support. However, in children who experience severe allergic reactions after the first dose, it is prudent to use a different brand for the second dose. But because there are only 2 vaccines being used at the moment, the second dose is put on hold until other vaccines become available. Vaccination after infection, the timing of vaccination of children who had COVID-19 vaccination is still under investigation, but most recent developments show that there should be an interval of at least 12 weeks between recovery and the vaccination. And finally, as Dr. Bergantin said, because infections are still possible in children and they can transmit the virus even after being fully vaccinated, masking, hand hygiene, and physical distancing should be followed in areas being frequented by children. So in the future, especially in schools. Thank you, Dr. Navarra. That's all.
Thank you, Dr. Collante. And of course, the topic of Professor Bonfa was really on the focusing on SLE and their response, antibody response to SARS-CoV-2 vaccine in SLE. And the main points, the conclusion of that very elegant study was that in terms of CoronaVac for ARD patients, there's moderate immunogenicity, 70% for naive and 78% for including the pre-exposed, although lower than controls, and vaccine type may not be a major factor for immunogenicity in lupus patients, perhaps. And glucocorticoids and MMF are the most relevant factors to impair immunogenicity in lupus patients. Overall, vaccine is safe. Dr. Bonfa, Professor Bonfa, would you like to elaborate more on this, including your experience in Brazil? That was one of the ground zero in terms of when that's the start of the COVID pandemic.
Okay, Sandra, thank you so much. And I would like to congratulate for the high level of this presentation. All presentation, I learned a lot tonight. Was worth staying late at night. And I would like to say that this presentation of mine is part of very large phase 4 study with 910 autoimmune rheumatic disease patients. So it's a very large study, which was published in Nature Medicine. And we have demonstrated that CoronaVac is effective, has a moderate response, immune response. It's almost 80% when we included seropositive patients, which most studies have done that. And we also demonstrated that it decreased the incidence of COVID in this population. We are observing these patients since February 2021. And we had an 81% decrease in the incidence of COVID 40 days after the second dose. And these remain to today that we are following these patients. So it has been very effective in spite of the spread of the Delta variant. This is distinct from the mRNA vaccine, in which we know that there is reduced immunogenicity, and also we had increase in cases, and in some place also increase in hospitalization. We did not have that in Brazil, and in particular in our patients that were immunized with CoronaVac vaccine. So I guess there is an economic force, very strong one, because we have a New England Journal paper demonstrating 10.2 million persons the protective effect of CoronaVac. And it's very safe. We didn't even have moderate side effects, only mild side effects in this population. And we also now finished the study with demonstrating that the durability of these patients is being revised now. After 6 months, we do have a reduction in antibody, 23% reduction in IgG and 41% of NAB positivity without the increase of incidence of case in spite of the Delta variant being more than 95% in the city of São Paulo. We also performed a booster dose in our patients, and it's incredible because we have 77% increase in antibodies, in IgG antibodies in this population overall. And we also have a very impressive increase in the level of antibodies and also in NAB positivity. But the 77% increase in antibody in those that were negative is very impressive and very reassuring for this group of patients. And we also performed some studies discontinuing MMF in this population. And we do see an increase 1 week discontinuation. We do see an increase in antibody response if we use this strategy. I think overall, what we saw was that for mRNA and coronavac vaccine, for both, we have a moderate response. It was lower, with 2 doses, was lower than the observed in the control population. But for coronavac, it's very important to have the second dose, because with the first dose, you don't have a very good response. So we have now a very large experience with this very large population. The durability study has more than 800 patients, and we are very comfortable saying that this vaccine is safe and it has a very good response in patients with lupus. Thank you.
Thank you very much. And I'm sure there are still a lot of other questions out there, although it seems like you have answered some of the questions that are posted already on chat. So thank you for that, Eloisa, and please stay on. We do have, we're running over time, but I'm sure the audience would like to have their questions answered even just this time. And at this point, I'd like to share with you some of the local experience that we have at the University of Santo Tomas. At this point, these are still unpublished. We still are continuing to gather data and doing analysis on this data. But I would like to acknowledge the work of our fellows, rheumatology fellows, with the help of Dr. Leonid Zamora on this. We have Wenz, Danielin, and we have Vince, Peter, as well as Eric. So those are the E's, the symbols or that we have in here. So this is done at the University of Santo Tomas. Now, for the first point, just to give you an overview of the preliminary data that we have on the severity of COVID-19 infection in lupus patients, and these were 36 lupus patients. Most of them actually had mild infection. In terms of outcome of their COVID-19 infection, majority of them were actually recovered from the COVID infection, and hospitalization was in less than 50%. So, and this is an important question, like how many of these patients with COVID-19 infection, lupus patients, had prior immunization? Actually, majority of them did not have any prior vaccination, and three had incomplete vaccination at the time of COVID infection, and only 4 were fully vaccinated at the time of COVID-19 infection. Now, what were the implications of that? One sees here that in terms of vaccination, those who did not have vaccination actually had 2 deaths there, and there were severe to critical in those with no vaccination, whereas none of this, there were no deaths and no severe to critical COVID occurring in those who were partially or fully vaccinated. So supporting really the fact that these patients do have a lot of benefit to gain from this. On the other hand, we need to look at the reality that you do get autoimmune reactions associated with SARS-CoV-2 vaccines in rheumatic disease patients, and we'd like to share this with you also. And here are the authors underneath here. I'd like to focus on our lupus patients, and these are 3 cases. One is a lupus flare following the first dose of SARS-CoV-2 vaccine. She was having stable disease, low disease activity until June 1, when she received her first AstraZeneca first dose. And following that, 3 weeks later, she developed generalized rashes, as you could see here, accompanied by leukopenia, hypocomplementemia with increase in anti-double-stranded DNA. And indeed, this was lupus activity. And skin biopsy showed interface dermatitis consistent with lupus erythematosus. Now, thankfully, with just high-dose steroids, she improved. The next question was, do we give the second dose of the AstraZeneca vaccine? And we had to give it because it was mandated by the company. She couldn't go back there until she was completely vaccinated. Well, she did receive the second dose, which was uneventful. She did not have any reactions to this, although she was still on low-dose steroids. The second case is that of a severe lupus flare following vaccine. So 57-year-old female who was in remission for several years off hydroxychloroquine, off steroids, off any of these lupus medications. And then she had her Sinovac 2 doses in April and May 2021. And a month later, she had a lupus flare, really severe lupus flare, which she said, "Doc, I never had this before. So why is it occurring to me now?" And she had mucocutaneous alopecia, rhamnosus ulcer, hematologic, hemoglobin dropped to 86, and she had nephritis. So it's which was previously normal. It was stable before. So we now she's now ongoing treatment. Seems to be improving, but still ongoing treatment for steroids, hydroxychloroquine, and mycophenolate mofetil, and we're closely monitoring her for that. Now, on itself, a very, very interesting case of a patient with lupus nephritis combined with thymoma, stable disease for a very long time. And she did have CKD, but her creatinine clearance was fairly stable over the last few years, not even months, few years, it was stable. Even her blood counts were stable then. And then she received June and July 2 doses of Sinovac. A month later, or just, a month later, she just came to the clinic. She was very dizzy, she was ecteric, there were no gross bleeding, and creatinine was stable. There was no reason to think that it was coming from the kidneys. And her hemoglobin really dropped down suddenly for no apparent reason at 64. And it did look like a hemolytic anemia with a jaundice there with high reticulocyte count. And WBC likewise was low, and she had a low C3. And if you compute her SLEDA, it was up to 15. So very active disease, but particularly focusing on the autoimmune hemolytic anemia. And while we were just working her through this, 3 weeks later, barely a month later, after she presented with the hemolytic anemia, she went to the hospital, had to enter the hospital because of severe COVID pneumonia. She received high-dose steroids, blood transfusion of remdesivir, bevacizumab, antibiotics, all the works for this patient. Well, thankfully, she improved. So she was discharged, improved after a month in the hospital, and her hemoglobin was stable at 95. So again, those 3 cases in which are case reports, actually these case reports, did some have some connection, has some association with COVID vaccine. So along this line, we have, of course, very appropriate to talk on tipping the balance here, will be my good friend, Dr. Juan Javier Lichao, who is the Chief of Rheumatology at St. Luke's Medical Center and the President of the Philippine Rheumatology Association. So a lot of burning questions, and we can't seem to get the answers, final answers for them. Jambi?
Hello, good morning, Dr. Navarra, and good morning to everyone. So I just wanted to start by, after hearing everyone, that the interplay between lupus, infections, and interventions like vaccines is a very complicated one. And it is often difficult to strike a balance in managing these patients to provide the best outcome for our patients. So I wanted to start by talking about lupus and COVID-19 infection. And we did mention that there are convergent pathways that may affect the response of lupus patients to COVID-19 infection. We have mentioned different important cytokines and pathways that are important in the pathogenesis of lupus that also may play a role in the way that our patients also respond severely in terms of a hyperactive immune response to the COVID-19 infection. Based on common observations from the COVID-19 Global Rheumatology Alliance, which is a worldwide registry looking into the effect of COVID-19 in rheumatic disease patients, and also based on local data, we know that there are certain risk factors in our patients associated with worse outcomes, and that would include older age, being Asian because of multifactorial issues. Comorbid conditions also increase the risk for worse outcomes, and always our culprit is the use of steroids. With regards to COVID-19 vaccination and lupus, based on the available data, there is no effect of lupus activity on seroconversion. But again, it is important to emphasize the effect of steroids. And based on the presentation of Dr. Bonfa, at least a dose of 10 milligrams per day of steroids can really make a difference in terms of the effect or the magnitude of the response of vaccines in our patients. But interestingly, in terms of other immunosuppressants, based also on the data presented by Dr. Bonfa, MMF is an important drug to consider, especially in terms of its effect on the coronavac immune response. Again, it is important to emphasize the timing of vaccination in relation to concomitant immunomodulating therapy is always important to consider. And I urge everyone to look into the recommendations from the latest ACR guidelines by Dr. Curtis. And I put it here as a reference because it provides us with important information about how to balance the timing of these important therapies with regards to COVID-19 vaccination. May I have the next slide? I think that the last item that I wanted to discuss is about autoimmune phenomenon after COVID-19 vaccination. And it is important to remember again that lupus patients are a special population and they cannot be compared to the general population. And in terms of autoimmune phenomenon, it is interesting to note that it has been observed in various types of COVID-19 vaccine, and that it can be seen even in quiescent lupus patients, and that the typical flares that we see in these patients involve new organ systems that were not previously observed. So I wanted to end by stating or quoting a particular statement from the latest ACR recommendations that beyond known allergies to vaccine components, there are no known additional contraindications to COVID-19 vaccination for those patients with autoimmune inflammatory rheumatic diseases. But I think after listening to the presentations and the case reports, I think that these are important points to think about, and that as we gather and generate more data, it is important because I think we can refine and improve our recommendations for our patients. Thank you very much.
Thank you, Dr. Lichauco, and thank you, everyone. I know we don't have a time anymore. It's running late on Professor Bonfa, but let's all just come for maybe just 5 minutes to answer some of these burning questions that have been coming up. Can we have all the panelists on board? And we start off with some of these questions in here. So we have, okay, some of the questions are, there are a lot of questions actually on immunization. So Professor Bonfa, yeah, sorry, it's running late in Brazil.
No, don't worry. I'm having fun.
Is there a recommended protocol to hold steroids for those planning to get vaccinated? Do you hold steroids?
Okay. No, we don't have this protocol, and I don't think the recommendation we have for EULAR and ACR, they are not based on evidence. We need more evidence for holding medications, but in our experience for RA, we increase 20% immunogenicity when we hold methotrexate, and it's safer for vaccines that have a large 2-dose apart longer because it increased the chances of activity in RA. For lupus patients, MMF, we did not see active disease if you hold the medication in patients that are not in active disease. And for steroids, we have not done that because there was no recommendation. It would be very difficult for us to hold 2 drugs and risky for the patients.
Yeah, so it seems like even from the presentation earlier, and that would answer also another question here on recommended interval of holding lupus meds. I think that was answered already, especially in terms of MMF, like hold it 1 to 2 weeks after the vaccine.
We hold steroids, 1 week. We hold 1 week after each dose. That's after what we did for MMF, and for methotrexate 2 weeks. So not 2 weeks. We hold during 2 weeks. Yeah.
Okay. Dr. Bergantine, we'd like to answer this question. As participants of a Catholic majority countries, there may be a concern which vaccines to use. Use fetal stem cell lines, and which can we use if there are, if ever that does not contradict our faith. That may apply also to Brazil, Eloisa. Do you have these issues with you? But let's have Dr. Bergantine answer that.
Okay, so we have to clarify first. These are immortalized cell lines, okay, and they are not crafted basically solely for the creation of the vaccines. But we also have to understand that these immortalized cell lines have been there ever since the production of, let's say, medications, as well as in terms of vaccines, for polio vaccine, for measles, for some other vaccines, not just solely for COVID. Now, I think initially at the start of this pandemic, there has been certain issues with regards to the production of vaccines using, I think, Pfizer and Moderna, wherein they use some of the cell lines just as a proof of concept that these vaccines can enter the cell. And I think the Catholic Church did not find anything unethical with regards to that, because they did not directly use these cell lines for that. And even with the use of the other vaccines, which I believe another one of those controversial ones will be the Johnson and Johnson vaccine, wherein they think have utilized if I remembered correctly, a retinal cell line. Again, they do not contain these vaccines. They do not contain aborted fetal cells. Okay, they have just used this as part of the immortalized cell lines where these vaccines or these viruses can grow. So, having been reviewed by the Catholic Church, they did not find anything which is directly how do you call this, immoral in doing this, simply because at this point of pandemic, the benefits of the vaccines really need to be highlighted. It's our moral obligation to get vaccinated. Now, in line with this, however, for those patients who would rather choose vaccines which are not which have been manufactured utilizing any cell line, then that is encouraged. But then if there are no alternatives, still, again, the position of the Catholic Church is that they do not find anything immoral with this kind of studies utilizing the cell lines of aborted fetus. Thank you.
Eloisa, did you have anything to add to that? Do you have the same issues in your country?
I never thought about this question, but I don't think in Brazil it's so relevant, because in Brazil, people are used to take vaccine, and we have a very big population that are in favor of vaccine. Although we have a small one that are not in favor, most people don't ask where the vaccine comes from, and they want to take the vaccine. We have big lines, people are fighting to take vaccines. So this is very good for Brazil. For example, in São Paulo, we have almost reaching 80% of the population full dose vaccination, and Brazil is vaccinating very fast. So I think this is the reason that we had a very great decrease in COVID cases, in spite, for example, that São Paulo has been the center of COVID cases. For example, our hospital hospitalized more than 11,000 patients in these two since March 2020. But now we don't have any more, we don't need more beds for COVID in our hospital.
Yeah, that's nice to know, and that certainly reinforces the fact that they have more benefit outweighing the risk for this. Have you encountered cases of vaccine-induced, we're having side effects or autoimmune reactions to vaccine, vaccine-induced thrombotic thrombocytopenia among patients given these vaccines?
I have not, but has been described one case in Rio de Janeiro, so it's very rare. And we have seen some patients with antiphospholipid syndrome who had a thrombotic event post-vaccine, not coronavac vaccine, the other vaccines, but we have not seen this syndrome.
Regarding booster doses of mRNA vaccines, is this single dose booster, or is this for Moderna, is this half the dose only? There's some confusion here.
Okay, so just to clarify, when we say it's booster, it should be a single shot. Okay, I think the only reason why most people would opt to have that quote unquote 2 doses is for them to receive another series of vaccines which have been emergency use approved in other countries where they would want to travel. So strictly speaking, when we say booster dosing, it's only a single dose. Now, with regard to the dose of Moderna vaccine, it's half of the dose that is recommended for priming. So for priming dose, it's 0.5 ml, but then for booster dosing, it's 0.25 ml.
Okay.
Thank you.
Yeah, thank you for that. And let's have this as a final question. What about the intervals with the other vaccines like flu shots? Dr. Bergantine or Teng, I think you answered that for children. The timing of the doses, like you get a COVID vaccine, especially for children, you get a COVID vaccine, then they need to get more vaccines. So do you know these are jobs, and children are almost like they fear many of these injections. So it's either Bergantine to answer that or Dr. Collante. Any interval between the COVID vaccine and the other shots that are necessary, like flu shots, from the adult standpoint. Dr. Bergantine?
Okay, so from the adult standpoint, there are no recommended interval between dosing. We're going to follow the general recommendations for vaccination. What we have now are not live vaccines, and I think the only ones which will really have interference with the production of antibodies are the ones which are live vaccines. So theoretically, there are no supposed to be effects with regards to the production of antibodies regarding the timing of the vaccination.
All right, Dr. Collante?
Yes, Doc. In children, multiple vaccines may be administered at the same time. So that's including COVID vaccine. So the most important vaccines that they should receive at the moment would be flu vaccine and then the anti-pneumonia vaccine. The only problem with children is that we only have 2 shoulders or 2 thighs. So they might not appreciate multiple injections more than 2 at a single visit. So if we need to maximize, we give 4 maximum. But if it is possible, we give 2 maximum at a single visit.
Okay, thank you. Thank you for that. I'm afraid we really have run out of time. I'd like to thank my heartfelt appreciation to all of you for making this possible and making this very engaging and interactive. Thank you so much. And now I will hand this over to my boss, Dr. Julie Lee Yu. Thank you.
Wow. Thank you very much, Dr. Navarra, and of course to our esteemed speakers, our guests, our panelists. Many, many thanks. So we give special thanks to our guest speakers, to our reactors, okay, and also to our UST rheumatology fellows who are working in the backstage with us here. Of course, this will not be made possible without the efforts of those who are behind the scene. So we give credits to Marlon as well as Robel, and of course to those who have been helping us in the chat box, as well as in the Q&A, in the other Zoom room, of course, the supporting roles of our colleagues. Thank you very much. This will not be possible again without the efforts of the University of Santo Tomas Section of Rheumatology, through very, very much thankful to Lupus Academy and the Philippine Rheumatology Association. And of course, what do you expect, our director and scriptwriter, none other than Professor Sandra Navarra. So I'd like to remind everyone to please complete the evaluation form through this link, okay? And you will receive your certificate of attendance thereafter. This webinar is also awarded with the following CPD units from the Philippine Academy of Family Physicians, Philippine College of Physicians, and Philippine Medical Association. Okay, so with that, may I invite the panelists, the guest speakers, the people behind the scene, our fellows, for a quick photo op. Thank you very much, everyone. Where is our photo op now? I cannot.
Thank you so much, Eliza.
Thank you so much. I learned a lot. Great meeting. Congratulations. The presentations were great. Thank you.
Thank you. Thank you. It's for us to really thank you. Wow, at such short notice.
No, it was very nice. It was very nice and very interesting and broad scientific topic.
Kindly extend also our thanks to the Lupus Academy for providing us this opportunity to work with Lupus Academy.
Okay, thank you. And can we have the recording while we are having the recording of the UST hymn and the final prayer?
Anyone who took the
Broadcast
picture?
that now?
I don't know.
Yeah, there's still, okay. Thank you. Thank you, everyone. You can have the picture. So all of you here, including our backstage people, including yourselves, we'd like to say thank you. Those are our fellows.
And our people in the other room, can they be elevated to this panel,
They will have
panelist
to
room?
put in the link.
Yes.
Uh,
Kaya ba? I don't know.
you're being broadcast. They're broadcasting, you know. You're seeing yourself on the other side.
Don't worry, I don't keep secrets.
Okay. Okay, you can actually close the webinar for now. Can you close the webinar for now? And we can have the others transferred to this Zoom link 1. So everyone transfers to the faculty room 1. Analysts and faculty room 1. All right, well, we're having to this. Can we just get some shots? And then we can copy and cut paste. You can play the UST hymn at the background if you wish to.
Oh, congratulations.
They're now here.
Echo.
Now,
Thank you.
officially end this webinar.
Are we taking
Thank you.
pictures? Everyone is here.
Congrats, everyone.
Wait, everyone is here. Let's take
Thank
a
you.
picture.
We can now officially end the webinar. Can we officially end the webinar?
Maybe in the output Zoom.
Thank you. Thanks, everyone, and thanks to all the participants.
Thank you.
My original backdrop. Look to that.
You're in the hospital and you're going. No.